Welcome, curious minds, to another deep dive. Today, we're plunging into a topic that literally runs through our veins and, well, influences the health of millions globally.
Indeed, it's a fascinating area.
It really is a field brimming with scientific breakthroughs, revealing the intricate dance, of our body's defense mechanisms.
Exactly. Our focus today is on blood clots, what they are, how they form, and crucially, the sophisticated pharmaceutical arsenal we employ to prevent and treat them.
Right.
And this deep dive isn't just about memorizing medical terms. It's really about mastering the underlying concepts, understanding how these critical interventions work at a foundational level.
So you can truly feel like an elite professional in this complex field.
That's the goal.
That's our mission. We're taking chapter 118 of our source material, antiplatelet, anticoagulant, and fibrinolytic drugs, and really unpacking every concept, every crucial detail. We want you, our listener, to walk away with not just knowledge, but genuine insight. We'll be your guides, trying to translate some dense medical information into clear, memorable understandings that hopefully stick.
Absolutely. We'll begin by sharply distinguishing between the two primary types of blood clots, then journey through the three major classes of drugs designed to combat them.
Okay.
And for each one, we'll explore their precise mechanisms, key indications, and the essential considerations. You'll discover not just what these drugs accomplish, but exactly how they achieve it.
And why those mechanisms are absolutely critical to their effectiveness.
Precisely. That difference makes all the difference.
Okay, let's unpack a fundamental distinction then, one that's crucial to understanding clot formation. Arterial versus venous thrombosis.
Yes.
They both involve blood clots, obviously, but their origins, their composition, and the dangers they pose are surprisingly different. It's not simply a clot forming, right? It's where and how it forms that dictates its character and the specific threat.
That's the critical insight here. It's quite fascinating how the local environment within a blood vessel dictates the nature of the clot. Let's start with arterial thrombosis.
Okay.
This typically occurs in high-pressure, high-flow environments.
So if you're picturing an artery, like imagine a high-speed, high-pressure pipeline. What's the common trigger for a clot in that kind of unforgiving environment?
Yeah, good analogy. Most arterial thrombi are commonly initiated by the rupture of an atherosclerotic plaque.
Oh, okay.
Think of that smooth pipeline, and suddenly there's a deep crack or tear in its inner lining. This isn't just a superficial scratch, it's an exposure of highly thrombogenic material, the reactive core of the plaque directly to the rapidly flowing bloodstream.
So stuff that was hidden is now exposed.
Exactly. Material that was safely hidden becomes this powerful trigger.
And once that highly reactive material is exposed, what's the immediate biological response? Does the body try to patch the breach instantly?
It's an almost instantaneous and very rapid cascade. This exposure triggers intense platelet aggregation, where platelets quickly clump together,
Right.
followed rapidly by fibrin formation. Imagine like an emergency patching crew rushing to seal a breach.
Makes sense.
The body's immediate goal is to plug that opening quickly, precisely because of the high blood flow and pressure inherent in arteries. It's an urgent, localized attempt to stop a leak.
And what does that emergency patch or the clot itself actually look like? What's its primary component?
Well, due to these high shear conditions that swift, powerful blood flow within arteries, these thrombi are predominantly platelet-rich.
Okay.
They're densely packed with platelets, giving them their characteristic white appearance. That's why they're often called white thrombi.
White thrombi, got it.
They're not just random clumps. They're highly organized platelet structures, maybe reinforced by a small amount of fibrin.
And when these white thrombi form in an artery, what's the immediate danger? What are the clinical consequences we see?
The consequences are severe, often acutely life-threatening. Think about vital organs suddenly deprived of blood flow.
Yeah.
We're talking about acute myocardial infarction, a heart attack, ischemic stroke where part of the brain is blocked, and even limb gangrene, where tissue dies due to lack of blood supply.
Wow.
All of these stem from this sudden or permanent occlusion of blood flow caused by these specific platelet-rich arterial clots. It's a critical medical emergency requiring immediate intervention.
Okay. Now let's switch gears to the other side, venous thrombosis. If arterial clots are about high pressure and plaque rupture, how do venous clots differ? Are they just like slower, more sluggish clots?
Yeah, that's a good way to think about the environment. In stark contrast to arterial clots, venous thrombi rarely form at sites of obvious vascular disruption. They're not typically triggered by a ruptured vessel wall.
Interesting.
Instead, they commonly originate in environments where blood flow is sluggish or even stagnant. Think about the valve cusps of deep calf veins or in muscular scientists.
Oh, okay. Those little pockets.
Exactly. This difference in blood flow dynamics is a fundamental environmental distinction.
So it's less about injury and more about the conditions within the vein itself. How does that slow, low-flow environment actually lead to a clot forming?
Precisely. The reduced oxygen supply to these vascular valve cusps, which is a direct result of the sluggish flow, actually activates the endothelial cells lining these areas.
Okay.
This activation causes them to express specific adhesion molecules on their surface. Then, tissue factor-bearing leukocytes and microvesicles adhere to these activated cells, initiating the coagulation cascade, that pathway leading to fibrin formation.
Right.
Now, here's where it gets really intricate. A key detail is the role of neutrophil extracellular traps, or nets.
Nets.
These are fascinating DNA structures extruded from neutrophils. They provide a scaffold that not only binds platelets, but also promotes their activation and aggregation. And importantly, nets even activate factor 12, an upstream clotting factor, further accelerating coagulation. And as you noted, the already impaired blood flow just makes it worse by reducing the clearance of activated clotting factors that would normally be washed away.
So if arterial clots are white and platelet-rich, what do these venous clots formed under low shear look like? Are they different in appearance?
They are quite different. These clots form under low shear conditions, meaning minimal fluid force or pressure. Consequently, they contain relatively few platelets compared to arterial ones.
Okay.
They're primarily composed of a dense fibrin mesh and trapped red blood cells, which gives them their characteristic red appearance.
Ah, red thrombi.
Exactly. They're often aptly described as red thrombi for this reason.
And the danger from these red venous clots, is it similar to the arterial ones, or does it manifest differently in the body?
The danger profile is quite distinct.
Right.
While a deep vein thrombosis, a DVT, can cause local issues like painful post-thrombotic syndrome, that's a chronic condition with pain and swelling in the limb, the gravest danger arises when fragments of these clots dislodge. These fragments, unlike arterial clots, are more prone to traveling because of their composition and, the venous system's direct pathway back to the heart.
So they can travel upstream.
Precisely. They can travel to the lungs, causing a pulmonary embolism, or PE. A PE can be acutely fatal. Or, if less severe, it can lead to chronic thromboembolic pulmonary hypertension, a serious long-term condition impacting the heart and lungs.
So despite these really distinct origins and compositions, do these two types of clots share any common risk factors? Or are they entirely separate phenomena in terms of who's susceptible?
That's an excellent question, and it speaks to systemic vulnerabilities. While their initiation pathways are somewhat unique, clinically, arterial and venous thrombosis share significant common risk factors.
Okay, like what?
Things like age, obesity, cigarette smoking, diabetes mellitus, arterial hypertension, hyperlipidemia, and metabolic syndrome.
The usual suspects, in a way.
Pretty much. Even select genetic variants, like those in the glutathione peroxidase 3 or GPX3 gene, have been linked to an increased risk for both types of thrombo-occlusive disease.
Interesting.
And importantly, both can also be triggered by pathophysiologic stimuli that activate inflammatory and oxidative pathways, suggesting a common underlying susceptibility to generalized vascular stress and inflammation.
But I've heard that hypercoagulability, the tendency for blood to clot too easily is understood differently for venous versus arterial issues, is what makes someone prone to a DVT, not necessarily what causes a heart attack.
You're absolutely right to pick up on that nuance. It's a critical distinction for understanding how we approach treatment. While hypercoagulability is extremely well understood as a major contributor to venous thromboembolism, VTE,
Right.
with specific genetic conditions like factor V Leiden and the prothrombin G2020-10A mutation being well-established risk factors for DVT and PE, their contribution to arterial thrombosis is much less defined. In fact, many of these thrombophilic factors, these genetic predispositions to clotting, have not been found to be clinically important risk factors for arterial thrombotic events, like acute coronary syndromes.
So the underlying triggers can be quite different.
Exactly.
Yeah.
It highlights that while there are shared systemic risk factors, the underlying biological triggers and primary mechanisms can be quite distinct. And this, in turn, directly impacts how we design and apply treatment strategies. It underscores that we cannot treat all clots the same way.
Right, that makes perfect sense. Now that we have a solid understanding of the two types of clots, the white platelet-rich arterial ones and the red fibrin-rich venous ones, let's dive into the treatment.
Okay.
Given that arterial thrombi are primarily white and platelet-rich, it makes perfect sense that our first line of defense often targets those tiny but powerful cells. Platelets.
Exactly. It's a highly targeted approach based on the clot's primary building blocks.
Wow.
In healthy blood vessels, circulating platelets are kept in a beautifully inactive state by a delicate balance of factors.
How so?
Endothelial cells lining the blood vessels release nitric oxide, NO, and prostacyclin. Both are powerful natural platelet inhibitors.
Okay.
Additionally, these same endothelial cells express a molecule called CD39 on their surface, which acts as an enzyme to specifically degrade ADP, a potent platelet activator that might be inadvertently released.
So it's like a constant surveillance system.
Exactly, a constant surveillance and deactivation system, keeping platelets calm and flowing.
So when a vessel is damaged, this delicate balance is disrupted and the platelets go from inactive to active. Can you walk us through that platelet activation cascade? How do they get activated and how do they then start building a clot?
Absolutely. When the vessel wall is damaged, that protective balance is immediately disrupted, exposing the critical subendothelial matrix, the layer beneath the endothelium, to the bloodstream.
Right, the stuff underneath.
Yes. This matrix includes highly reactive components, particularly collagen and von Willebrand factor, or VWF. Platelets quickly adhere to this exposed collagen via specific receptors, like angiotensin-1 and GP6, and to VWF via GP-IBA and GP-IBA.
They grab on.
They grab on, and once adherent, they undergo a rapid change in shape, transforming from a smooth disc to a spiky sphere, which increases their surface area for interaction. Crucially, they then release powerful platelet agonists like ADP from their dense granules, and they also synthesize and release thromboxane A2, or TXA2.
Okay.
These release agonists then act on ambient platelets, activating them and recruiting them to the precise site of injury, creating a growing plug.
And this isn't happening in isolation, is it? Doesn't the coagulation cascade also kick in simultaneously? It feels like everything is happening at once.
You're absolutely right. It's a highly coordinated, simultaneous process. At the very same time platelets are activating, the disruption of the vessel wall also exposes tissue factor-expressing cells to the blood.
Tissue factor, the trigger.
The primary initiator of the coagulation cascade. It binds factor, the EA, which then rapidly generates thrombin. Now, here's where it gets really interconnected. Activated platelets actually potentiate coagulation by providing a negatively charged surface that binds clotting factors. This supports the assembly of activation complexes that significantly enhance thrombin generation.
Wow.
And thrombin itself, besides converting fibrinogen to fibrin to solidify the clot, is also a potent platelet agonist, amplifying platelet recruitment.
So it feeds back into the system.
It feeds back, exactly. Yeah. Thrombin further amplifies its own generation and solidifies the fibrin network by activating factor 13, which cross-links the fibrin strands, making the clot much stronger, more resilient.
And the final step for platelets clumping together.
The key final common pathway for platelet aggregation, regardless of the initial trigger, is the conformational change in GP-IBA, the most abundant receptor on the platelet surface. Once activated, this receptor allows it to bind fibrinogen and, under high shear, VWF, bridging adjacent platelets together to form the initial platelet aggregate, which is then reinforced by fibrin.
So, given that incredibly intricate multi-step process, how do we strategically design drugs to stop it? Where are the critical points of intervention for antiplatelet drugs?
It means we have very specific and clever targets. Antiplatelet drugs are designed to disrupt various steps in this intricate dance of platelet activation and aggregation.
Okay.
We have 5 main categories, each with its own precise point of intervention. Aspirin targeted at key enzyme in the TXA2 pathway.
The classic.
The classic. Then ADP receptor inhibitors, blocking a crucial activation signal. Dipyridamole, a lesser-known player, often combined. GP-IBA antagonists, hitting the final common pathway of aggregation itself. And Vorapaxar, a newer drug targeting thrombin's effects on platelets.
Let's start with aspirin, probably the most well-known antiplatelet drug out there, sitting in many medicine cabinets. How does it work at a molecular level to prevent clots?
Aspirin is, well, globally the most widely used and forms the foundation of most antiplatelet strategies. Low cost, remarkable effectiveness.
Right.
Its antithrombotic effect comes from irreversibly acetylating and inhibiting platelet cyclooxygenase 1, or COX-1.
COX-1.
This enzyme is absolutely crucial for synthesizing thromboxane A2, TXA2, which, as we discussed, is a powerful platelet activator and aggregator.
So it shuts down TXA2 production.
Exactly. By irreversibly blocking COX-1, aspirin effectively shuts down TXA2 production for the entire lifespan of that platelet, which is about 7 to 10 days.
Wow, irreversible.
Irreversible. New platelets must be produced for the effect to wear off. Now, at much higher doses, around a gram per day, it also inhibits COX-2, an inducible isoform in endothelial and inflammatory cells.
Okay.
COX-2 synthesizes prostacyclin, which actually acts as a vasodilator and platelet inhibitor. So this dual action at higher doses can sometimes complicate things, suggesting higher doses aren't always better for the antiplatelet effect alone.
So what are the main clinical uses for aspirin, and why is there some ongoing debate or controversy around its use, especially for prevention?
Yeah, the prevention question is key. Aspirin is widely established for what we call secondary prevention.
Meaning after an event.
Exactly. For patients who have already experienced or have established coronary artery disease, cerebral artery disease like a previous stroke, or peripheral artery disease. In this setting, aspirin significantly reduces the risk of CV death, MI, or stroke. That benefit is very clear.
Okay.
However, its use for primary prevention, preventing a first event in seemingly healthy individuals, has become more controversial.
Why is that?
Recent studies have seriously questioned whether the benefits of daily aspirin for primary cardiac protection truly outweigh its associated risks, particularly for gastrointestinal and intracerebral hemorrhage.
The bleeding risk.
The bleeding risk.
Yeah.
Consequently, current guidelines generally no longer recommend aspirin for primary cardiac prevention unless the patient's baseline cardiovascular risk is demonstrably high, typically at least 1% per year and 10% over 10 years. It's a careful balancing act.
Needs individual assessment.
Definitely. And interestingly, we are seeing new strategies emerging, like adding low-dose rivaroxaban, an oral factor ZAB inhibitor, to dual antiplatelet therapy. That's shown promise in reducing recurrent ischemic events in ACS patients.
Right.
And adding it to aspirin alone reduces major adverse coronary and limb events in stable coronary or peripheral artery disease. So the landscape is evolving.
When it comes to aspirin, does a higher dose always lead to better prevention?
Not at all. And this is a key takeaway for you, the listener. For most indications, a daily dose of 75 to 100 milligrams is recommended.
A low dose.
Low dose. It's crucial because higher doses are generally not more effective than these lower doses for antiplatelet effects, and some analyses even suggest reduced efficacy with excessively high doses. Plus, side effects are dose-related.
Okay. What if you need it to work fast?
Good question. If rapid platelet inhibition is needed, like in a suspected heart attack, an initial loading dose of at least 160 milligram is typically given to achieve quick saturation of that COX-1 enzyme.
And what are the common side effects that our listeners should be aware of with aspirin, especially the more serious ones?
The most common are gastrointestinal. Anything from simple dyspepsia, indigestion, to more serious issues like erosive gastritis or peptic ulcers with potential for bleeding or even perforation.
And these are dose-related?
Yes, definitely dose-related.
Yeah.
Unfortunately, using enteric-coated or buffered aspirin, while often marketed as gentler, doesn't eliminate these GI side effects entirely.
Okay.
The overall risk of major bleeding with aspirin therapy is about 1–3% per year. But this risk significantly increases, maybe 2 to 3-fold, when aspirin is given with other antiplatelets, like clopidogrel, or with anticoagulants like warfarin.
So dual or triple therapy needs extra caution.
Absolutely.
Yeah.
In those cases, it's even more critical that low-dose aspirin, 7,500 milligrams daily, is used. Strategies like eradicating H. pylori infection and using proton pump inhibitors can help reduce the risk of upper GI bleeding in some patients.
Any specific contraindications?
Yes. Aspirin shouldn't be given to patients with a history of aspirin allergy, particularly if it involves bronchospasm. It's rare, about 0.3% of the population, but more common in people with chronic urticaria or asthma, especially with nasal polyps. Also, overdose can cause liver and kidney toxicity.
I've heard the term aspirin resistance. What exactly does that mean, and how is it defined in a way that's clinically useful? Is it a real thing?
Yes. This is a complex and often misunderstood concept. Excellent point for an elite professional to grasp. Clinically, aspirin resistance is often defined retrospectively.
Meaning after the fact.
Yeah, as the failure of aspirin to protect patients from ischemic vascular events. Someone on aspirin still has a heart attack or stroke. But this is a problematic definition because Well, it's made after the event, and it's simply not realistic to expect aspirin blocking only one pathway to prevent all vascular events.
Right. So how is it defined biochemically?
A more precise definition is biochemical aspirin resistance. This is a failure of the drug to produce its expected inhibitory effects on lab tests of platelet function, like thromboxane A2 synthesis or platelet aggregation tests.
So what causes this biochemical resistance? And if it's detected, does it change how we treat patients?
Potential causes include practical things like poor patient compliance, just not taking the drug, reduced absorption, drug interactions, especially with NSAIDs like ibuprofen and maybe KOX2 overexpression. Unfortunately, the tests for aspirin resistance aren't well standardized, so results can vary.
And does testing help?
Well, more importantly, there's currently little robust evidence from clinical trials that identifying this biochemical resistance actually improves patient outcomes, or that giving higher doses of aspirin or adding other antiplatelet drugs effectively reverses it in a clinically meaningful way.
So it's more of a research concept for now.
Essentially, yes.
Wow.
The key insight here is that while aspirin resistance exists biochemically, its clinical utility for guiding therapy remains a research frontier rather than routine practice. It just underscores that even foundational drugs like aspirin aren't one-size-fits-all. Patient variability is always a challenge.
Okay. Beyond aspirin, we have a whole class of drugs that target a specific ADP receptor on platelets called P2Y12. These are the ADP receptor antagonists. Sounds like they're hitting a different but equally crucial part of that platelet activation cascade.
Exactly. ADP is a major player in amplifying platelet activation. This class includes several important drugs.
Yeah.
The thienopyridines, which are older but still widely used like clopidogrel and prasugrel, and also newer, more potent agents like ticagrelor and the IV drug canker, all specifically target P2Y12, that key ADP receptor on the platelet surface.
Let's start with the thienopyridines, clopidogrel, and prasugrel. How do they work, and what are their key differences in terms of potency and onset of action?
The thienopyridines are structurally related drugs that selectively inhibit ADP-induced platelet aggregation by irreversibly blocking that P2Y12 receptor.
Irreversibly again, like aspirin.
Yes, irreversible.
Yeah.
But a critical point is that both clopidogrel and prasugrel are prodrugs.
Meaning they need to be activated.
Correct. They are inactive when taken and require metabolic activation by the hepatic cytochrome P450 or CYP enzyme system in the liver to become effective. Prasugrel is notably about 10 times more potent than clopidogrel and has a more rapid onset of action.
Why is that?
It's because it has better absorption and a more streamlined metabolic activation pathway compared to clopidogrel, making its effect quicker and more pronounced.
Where are these thienopyridines typically used, and how do they compare in terms of efficacy and bleeding risks, especially when combined with aspirin?
Clopidogrel, when compared with aspirin in patients with recent ischemic stroke, MI, or peripheral arterial disease, showed a significant, though modest, reduction in the risk of cardiovascular death, MI, and stroke. So it's more effective than aspirin in these settings, but also more expensive.
And the combination.
The combination of aspirin plus clopidogrel is very common because they block complementary pathways. This dual antiplatelet therapy, or DAPT, is recommended for at least 4 weeks after a bare metal stent and for at least a year with drug-eluting stents.
Maybe even longer for DES.
Yes, some experts recommend longer for drug-eluting stents due to concerns about late-in-stent thrombosis. In unstable angina patients, this combination significantly reduced major cardiovascular events compared to aspirin alone.
But what about the bleeding trade-off?
That's the key trade-off. Combining clopidogrel with aspirin increases the major bleeding risk to about 2% per year, even with low-dose aspirin. So it should only be used when there's a clear benefit. For instance, it's not superior to clopidogrel alone for acute ischemic stroke, or to aspirin alone for primary prevention. You need that strong indication.
And what about prasugrel, the more potent one? Where does it fit in, and what are its particular risks?
Prasugrel was compared head-to-head with clopidogrel in a large study of patients with acute coronary syndromes undergoing PCI, or stenting.
Okay.
Prasugrel significantly lowered the composite efficacy endpoint CV death, MI, stroke, mainly by reducing non-fatal MI. Stent thrombosis was also significantly lower with prasugrel.
Sounds good.
But these advantages came at a cost. Significantly higher rates of fatal bleeding and life-threatening bleeding with prasugrel. Because patients older than 75 and those with a history of stroke or TIA have a particularly high risk of bleeding, prasugrel should generally be avoided in older patients, and it's contraindicated in anyone with prior stroke or TIA.
Got it. Other cautions.
Caution is also needed in patients weighing less than 60 kilograms or with renal impairment. Because of this profile, prasugrel is generally reserved for patients undergoing PCI, usually given with low-dose aspirin.
So for stroke or TIA itself, is dual antiplatelet therapy also an option like it is for heart issues?
Yes. For patients with non-cardioembolic stroke, not from a heart clot or high-risk TIA, the combination of either clopidogrel or ticagrelor plus aspirin for about 21 to 30 days.
Short term.
Short term, yes. Followed by aspirin alone thereafter has been shown to reduce the risk of stroke, MI, and vascular death by up to 30% compared with aspirin alone. So DIPT is often used for the first few weeks in those patients.
What are the typical doses for clopidogrel and prasugrel, and what are their main side effects beyond bleeding?
Clopidogrel is typically 75 milligrams once daily. When a rapid effect is needed, like before stenting, loading doses of 300-600 milligrams are given.
Okay.
For Prasure, after a loading dose of 60 milligrams, it's 10 milligrams once daily. But for patients over 75 or under 60 kilograms, a lower dose of 5 milligrams should be used.
And side effects?
Bleeding is the most common for both, more so with prasugrel due to its potency. They should generally be stopped 5-7 days before major surgery. Platelet transfusion might help with serious bleeding, but it's not always effective. Rare hematologic side effects like neutropenia, thrombocytopenia, and TTP can also occur.
And then there's this concept of phenotopyridine resistance, particularly with clopidogrel. What exactly is that, and how does it impact treatment decisions?
Yes, the effectiveness of clopidogrel varies significantly between individuals. This variability largely reflects genetic polymorphisms, or variations, in the CYP isoenzymes involved in its metabolic activation.
Those liver enzymes again.
Exactly. Specifically, CYP2C19 is the most important. Patients treated with clopidogrel who carry certain loss-of-function variants, like the CYP2C192 allele, exhibit reduced platelet inhibition compared to those with the normal allele.
And the consequence?
Consequently, they experience an increased risk of cardiovascular events. And this is highly relevant because these variants are quite common, especially in certain populations like Asians. Even patients with other reduced function alleles may get less benefit. Plus, certain proton pump inhibitors, which also inhibit CYP2C19, can slightly reduce clopidogrel's effect, though the clinical impact of that interaction is still debated.
So if someone is identified as a poor metabolizer of clopidogrel through genetic testing, what happens? Are there alternative strategies?
Interestingly, genetic variations in CYP2C19 seem less important for prasugrel's activation, meaning its effect is generally more consistent.
Okay.
Now, the observation that genetics influence clopidogrel outcomes naturally led to the idea of pharmacogenetic profiling testing patients beforehand.
Makes sense.
It does, but clinical trials evaluating whether this approach actually improves outcomes have, so far, yielded negative results.
Really? Why?
It's complex. While giving higher doses of clopidogrel can overcome the reduced response biochemically, the clinical benefit is uncertain. Instead, for these patients, the more potent alternatives like prasugrel or ticagrelor might be better choices, offering a more predictable effect and bypassing that specific metabolism issue.
This one, ticagrelor, sounds like it bypasses some of those resistance issues you just described with clopidogrel. What's its unique mechanism?
Precisely. Ticagrelor is an orally active P2Y12 inhibitor, but it differs from the thienopyridines in two crucial ways. One, it does not require metabolic activation by the liver.
So no prodrug issue.
No prodrug issue. And two, it produces reversible inhibition of the ADP receptor, unlike the irreversible action of clopidogrel and prasugrel.
Reversible, interesting.
Yes.
Yeah.
Because it doesn't need metabolic activation, ticagrelor has a more rapid onset and offset of action compared to clopidogrel, and it consistently produces greater and more predictable inhibition of ADP-induced platelet aggregation.
Yeah.
This avoids that resistance problem.
So where is ticagrelor typically indicated, and what about its dosing and unique side effects?
Ticagrelor is indicated for secondary prevention of antithrombotic events in patients with acute coronary syndrome, whether treated medically with PCI or CIBG surgery.
Broad indication.
Yes. It's also indicated for up to 3 years for secondary prevention in patients with a prior MI at least 1 year ago who remain at high risk. Current guidelines often prefer ticagrelor over clopidogrel, especially in higher-risk patients undergoing PCI because of its potency and predictability.
And dosing.
It's initiated with an oral loading dose of 180 milligrams, followed by 90 milligrams twice daily. No renal adjustment needed, but caution with hepatic disease or potent CYP3A4 inhibitor inducers as it's metabolized via CYP3A4, usually given with low-dose aspirin.
Any unique side effects besides bleeding?
Yes, in addition to bleeding, the most notable side effects are dyspnea, or shortness of breath, which can occur in up to 15% of patients.
Wow, that's quite high.
It is, but it tends to occur soon after starting, is usually mild, and often self-limiting. The mechanism isn't fully known. Also, asymptomatic ventricular pauses can occur. Like the others, it should be stopped at least 5 days before major surgery.
And if someone bleeds anticoagulant?
A key point for you, the listener. Platelet transfusion is unlikely to help much because the drug is reversible and present in the plasma, so it will bind to the new platelets P2Y12 receptors too.
Okay.
However, there's an exciting development. Bentracimab, an antibody fragment, is currently under development specifically for anticoagulant reversal. That could be a significant breakthrough for managing bleeding risk.
Another P2Y12 inhibitor, but this one's IV Cangular. What's its specific role, particularly in the acute setting, maybe in the cath lab?
Exactly, it's primarily a cath lab drug. Cangular is a rapidly acting, reversible IV P2Y12 inhibitor. It's specifically licensed for use in patients undergoing PCI who haven't received pre-treatment with oral P2Y12 inhibitors.
So for immediate effect during the procedure?
Precisely. It provides immediate ADP receptor blockade. It's given as a 32Y IV bolus right before PCI, followed by a continuous infusion of 4 more Ngibs per minute for at least 2 hours or the duration of the procedure.
And how do you transition off it?
When transitioning to oral therapy, ticagrelor, 180 milligram loading dose, can be given anytime during or immediately after the cangrelor infusion. But importantly, loading doses of prasugrel or clopidogrel must only be given after cangrelor is stopped.
Why the difference?
Because cangrelor actively blocks the interaction of their active metabolites with P2Y12. If you give them simultaneously, the oral prodrugs won't be able to work effectively until the cangrelor wears off.
Got it. What about dipyridamole? I've mostly heard of it combined with aspirin in a drug called Agradox, not usually on its own. What's its unique mechanism?
You're right. Dipyridamole alone is considered a relatively weak antiplatelet agent. That combination product, Agradox, with extended-release dipyridamole and low-dose aspirin, is sometimes used for secondary prevention in patients who've had TIAs or ischemic strokes.
And its mechanism?
It's quite different. It primarily inhibits phosphodiesterase, an enzyme that breaks down cyclic AMP or CANC-MP inside platelets. By inhibiting this breakdown, dipyridamole boosts CMP levels. Increased CAMP reduces intracellular calcium, which in turn inhibits platelet activation. It also blocks the uptake of adenosine by platelets and other cells, which further increases local CAMP levels. So it works by increasing an internal messenger that essentially tells the platelet to calm down.
Does this combination with aspirin Agradox have strong evidence for its efficacy in stroke prevention compared to other options?
Well, early trials showed the combination reduced stroke risk compared to aspirin alone or dipyridamole alone. Another trial confirmed a reduction in vascular events compared to aspirin alone. But a large trial comparing Agradox head-to-head with clopidogrel for non-cardioembolic ischemic stroke showed quite similar recurrent stroke rates. Crucially, that study failed to meet the pre-specified margin to claim non-inferiority of Agradox relative to clopidogrel.
So not clearly better, maybe not even as good as clopidogrel in that setting.
Exactly. Those results have, understandably, dampened enthusiasm for its widespread use, especially given other available options.
Are there any contraindications or specific patient populations where Agradox should be omitted?
Yes. Due to its vasodilatory effects, it widens blood vessels, and limited data in patients with symptomatic coronary artery disease, Agradox should generally not be used for stroke prevention in those patients. Clopidogrel is considered a better choice there.
Okay. And side effects?
Agradox is given twice daily. Common side effects, also related to its vasodilation, include GI complaints, headache, facial flushing, dizziness, and hypotension, though these often subside with continued use.
Okay, this next class sounds like hitting the brakes right before aggregation happens, the very last step. These are the GP-IBIA receptor antagonists.
Precisely. This class of parenteral drugs given by injection, usually IV, has a very specific niche, typically in high-risk patients with acute coronary syndrome.
Why parenteral?
They need to work very quickly and potently in that acute setting. They target the final common pathway of platelet aggregation, preventing platelets from clumping together regardless of how they were activated. The 3 main agents are abciximab, eptifibatide, and tirofiabam.
So how exactly do they work to block this final common pathway? What's the molecular target again?
Glycoprotein iberia, or GP-iberia. It's the most abundant receptor on the platelet surface, about 80,000 copies per platelet. It's an integrin adhesion receptor.
Okay.
When platelets get activated, Various signals trigger a conformational activation of this receptor. Once activated, GPIBA changes shape, allowing it to bind adhesive molecules like fibrinogen and, under high shear, VWF.
The molecular glue.
Exactly. These molecules contain specific binding sequences, RGD or KGD. This binding acts as a bridge, linking adjacent platelets together, inducing aggregation, forming the core of the clot. These drugs block that very last crucial step.
And while they all block GPIBA, are they all the same or do they have distinct properties?
They definitely differ structurally and pharmacologically, which impacts their use. Efficacy is a Fab fragment of a humanized mouse antibody. Crucially, it binds the activated form of GPIBA with very high affinity. It has a long half-life, effects last up to 2 weeks, and it's not cleared by the kidneys.
Okay, what about the others?
Eptifibatide is different. It's a synthetic, cyclic peptide incorporating the KGD motif, mimicking a natural binding site. It has shorter plasma and platelet-bound half-lives and is cleared by the kidneys. Tirofiban is a non-peptidic molecule acting as an RGD mimetic. Like eptifibatide, short half-lives, renally cleared.
So given these differences, when are they typically used and what's the most serious side effect we need to worry about?
Efficacy and eptifibatide are primarily used in patients undergoing PCI, especially those not pretreated with an oral ADP receptor antagonist. Tirofiban and eptifibatide 2 are often used in high-risk patients with unstable angina. They're all given as an IV bolus followed by infusion.
And the big risk.
The most serious complication, common to all, is thrombocytopenia, a significant drop in platelet count.
Why does that happen?
It's an immune-mediated process. The body produces antibodies against new antigens, neoantigens, on the GPIBA receptor that get exposed when the antagonist binds. Efficacy causes it in up to 5% of patients, severe in 1%. It's less common, maybe around 1% with eptifibatide and tirofiban, but definitely something to monitor closely.
Okay, this last antiplatelet, vorapaxar, sounds quite specific. What exactly does it target in the platelet activation pathway?
Vorapaxar is an orally active PR1 antagonist. PR1 stands for protease-activated receptor 1. It's the major thrombin receptor on human platelets.
So it blocks thrombin's effect on platelets.
Exactly. It specifically blocks thrombin-induced platelet activation, which is a powerful amplification loop. What's notable pharmacologically is its very long half-life, about 200 hours.
Wow, that's long. And what have the clinical trials shown for vorapaxar, where its outcomes as promising as its targeted mechanism suggests?
Its journey through trials has been mixed, which is key to understanding its limited clinical role. In one trial in acute coronary syndrome without ST elevation, vorapaxar unfortunately failed to significantly reduce the primary endpoint.
And bleeding.
Yes, it was associated with increased bleeding, including intracranial bleeding. However, in a second, larger trial focusing on secondary prevention in patients with prior MI, stroke, or peripheral artery disease, vorapaxar did show an overall reduction in CV death, MI, or stroke by 13% compared to placebo. But again, this benefit came at a cost. It doubled the risk of intracranial bleeding across the entire cohort.
Oof, that's a significant trade-off. Was there a specific group that seemed to benefit more with less risk, leading to its current, somewhat narrow licensing?
Yes, exactly. There was a pre-specified subgroup of patients with a prior MI where the data looked more encouraging for efficacy. In this MI subgroup, vorapaxar reduced the risk of CV death, MI, or stroke by 20%. While intracranial hemorrhage was still numerically higher, it wasn't statistically significant in that subgroup. However, it did significantly increase moderate or severe bleeding.
So very specific patients only.
Very specific.
Yeah.
Based on these nuanced data, vorapaxar is licensed only for patients younger than 75 with MI or peripheral artery disease who have no history of stroke, TIA, or intracranial bleeding, and weigh more than 60 kilograms.
Quite restricted.
Very. It's given at 2.08 milligrams once daily. The major side effect, predictably, is bleeding. Platelet transfusion might help with reversal, but that long half-life is a challenge.
Okay, so if antiplatelet drugs target the platelet's key in arterial clots, then anticoagulants must be all about that fibrin part of the clot, especially for venous issues, right? Hitting the coagulation cascade itself.
That's an excellent way to conceptualize it. Anticoagulants are indeed the mainstay for preventing and treating venous thromboembolism, VTE, where fibrin is the predominant component.
Because platelets aren't the main issue there.
Exactly. Antiplatelet drugs have limited effectiveness there. Anticoagulants directly inhibit the coagulation cascade, preventing fibrin formation. We have both parenteral, injectable, and oral anticoagulants, each with distinct properties and uses. It's essential to understand the unique niche of each.
Let's start with heparin, specifically unfractionated heparin or UFH. It's been around forever, a workhorse drug. But how does it actually work at the molecular level?
Heparin is a fascinating molecule, a sulfated polysaccharide. Its primary anticoagulant action comes from activating antithrombin.
The body's natural brake.
Precisely, a critical plasma cofactor, a natural inhibitor of clotting enzymes like thrombin and factors As. Heparin binds to antithrombin via a unique pentasaccharide sequence found on about one-third of its chains.
Okay.
This binding induces a conformational change in antithrombin, accelerating its inhibition of factors Ad by at least 2 orders of magnitude. Now, for heparin to inhibit thrombin effectively, it needs to do more. It must simultaneously bind to antithrombin and thrombin, acting as a template, a bridge, to form a ternary complex. Only heparin chains of at least 18 saccharide units are long enough to do this bridging.
Ah, size matters.
Size matters here. Unfractionated heparin, with a mean molecular weight of 15,000, mostly consists of chains long enough to do this, giving it roughly equal capacity to promote both factors I and thrombin inhibition. It also causes the release of tissue factor pathway inhibitor, TFPI, from the endothelium, adding to its effect.
That's quite intricate. What are the practical considerations for how heparin is administered and behaves in the body? It sounds like it might be unpredictable.
It can be. Heparin must be given parenterally, usually subcutaneously for prophylaxis, or by continuous 5e infusion for therapy. When given therapeutically via subcutaneous route, the dose needs to be high enough to overcome limited bioavailability. In the circulation, heparin binds extensively to endothelial cells, which explains its dose-dependent clearance, shorter half-life at low doses, longer at higher doses once the endothelium is saturated. It also binds to various plasma proteins other than antithrombin.
Like what?
Things like acute phase reactants, VWF multimers, and importantly, platelet factor 4, or PF4, released from activated platelets. These heparin-binding proteins can significantly reduce heparin's anticoagulant activity.
So PF4 can neutralize it?
Yes, large amounts of PF4, often found near platelet-rich arterial thrombi, can even neutralize heparin's activity locally.
Given all that variability binding to different cells, proteins, how do clinicians monitor heparin's effect to ensure patients get the right dose?
Yeah, because the levels of these binding proteins vary. The anticoagulant response to fixed or weight-adjusted doses of heparin is unpredictable. Careful monitoring is essential. The activated partial thromboplastin time, or APTT, is commonly used, but it has issues with reagent sensitivity and machine influence. So labs must establish their own therapeutic APT ranges, typically 2-3 times prolongation, that correlate with therapeutic anti-factor Za levels, 0.3, 0.7 units SML.
What about heparin resistance?
Right. Up to 25% of patients, especially with VTE, may need very high doses to reach a therapeutic APTT. They're considered heparin resistant. Interestingly, in many of these cases, the anti-factor Za levels are actually therapeutic despite a low APTT.
Why would that be?
Often due to elevated fibrinogen and factor VIII, acute phase proteins that can shorten the APTT. In such cases, monitoring with anti-factor Za levels is preferred. Same for patients with antithrombin deficiency or high levels of those binding proteins.
So heparin has limitations beyond just monitoring.
It does. Pharmacokinetic issues include poor bioavailability at low SC doses, dose-dependent clearance, variable responses due to nonspecific binding. Biophysically, the heparin antithrombin complex works less well against factor demand already in the prothrombinase complex and against thrombin already bound to fibrin.
Meaning the clot can keep growing.
Yes, clot-associated thrombin can continue to promote thrombus growth even with heparin around. Plus, that PF4 neutralization issue in platelet-rich clots compounds the problem.
And the side effects of heparin. Beyond bleeding, what are the other crucial complications, particularly that one, heparin-induced thrombocytopenia, HIT?
Bleeding is, of course, the most common, risk increasing with dose and other drugs. Protamine sulfate is the antidote, binding heparin. But yes, heparin-induced thrombocytopenia, HIT, is critical.
How does it happen?
It's an antibody-mediated process, usually IgG antibodies targeting new antigens on platelet factor 4, PF4, that are exposed when heparin binds to it. These antibodies then bind to both the heparin PF4 complex and platelet Fc receptors, activating platelets and generating prothrombotic microparticles. Paradoxically, an anticoagulant causes clotting.
When does it typically occur?
Usually 5-14 days after starting heparin or earlier with prior exposure. Characterized by platelet count 100,000 or a 50% drop, more common in surgical patients, cancer patients, females. Critically, HIT can lead to severe thrombosis venous more often, but arterial too, including limb ischemia.
How is HIT diagnosed and managed? And I've heard something about a connection to some recent vaccine-related issues.
Diagnosis involves specific antibody tests, ELISA for sensitivity, serotonin release assay for specificity.
Mhm.
Management is crucial. Immediately stop all heparin,
All forms.
all forms, including flushes. Administer an alternative anticoagulant, argatroban, bivalirudin, fondaparinux, or rivaroxaban. Platelet transfusions are generally avoided as they can fuel thrombosis. Warfarin should not be given until platelets normalize and only with overlap to prevent warfarin-induced skin necrosis.
And the vaccine connection.
Yes, a similar syndrome, vaccine-induced thrombocytopenia, VITT, was seen rarely with adenovirus COVID-19 vaccines. Thrombosis and thrombocytopenia 4-28 days post-vaccination, often unusual sites like cerebral or splanchnic veins. Diagnosis involves PF4 antibody tests. Treatment can include IVIG, steroids, plasma exchange, and non-heparin anticoagulants.
What other heparin side effects should we know?
Osteoporosis with long-term therapeutic use over a month. Reduced bone density up to 30%. Symptomatic fractures in 2-3%. Heparin affects both bone formation and resorption. Also, modest asymptomatic elevations in liver enzymes are frequent, resolving on stopping. Mechanism unknown.
So low molecular weight heparin, or LMWH, sounds like a better version of heparin. What makes it superior for most uses, and why has it largely replaced UFH for many indications?
LMWH consists of smaller heparin fragments, meaning MW around 5,000, about a third the size of UFH. This smaller size gives significant advantages.
How does it work differently?
Like UFH, it activates antithrombin. However, with its shorter chains, at least half of the LMWH chains are too short to bridge thrombin to antithrombin.
Ah, back to the size issue.
Exactly. Its primary effect, therefore, is to accelerate factor ASA inhibition by antithrombin. LMWH preps have antifactors ASA to antifactor II ratios from 2.1 up to 4.1, reflecting this preferential ASA activity. That's a critical difference.
What are the practical implications of these pharmacokinetic advantages? Does it make dosing easier?
It does. LMWH is usually given subcutaneously. Its advantages stem from less avid binding to endothelial cells, macrophages, and plasma proteins compared to UFH.
Less non-specific binding.
Right. This means dose-independent clearance and a longer, more predictable plasma half-life, around 4 hours. It also has 90% bioavailability after SC injection, leading to a much more predictable dose response. Resistance is rare.
But kidney function matters.
Yes, crucially, it's almost exclusively cleared by the kidneys, so LMWH can accumulate in renal insufficiency. That's an important consideration.
This predictability sounds like a huge benefit. Does it simplify monitoring, which was a big issue with UFH?
Absolutely. Its longer half-life and predictable response mean LMWH can be given SC once or twice daily without routine coagulation monitoring, even at treatment doses.
Wow, that's huge.
It revolutionized care, enables effective and safe outpatient treatment for VTE, streamlining care, reducing costs, improving patient satisfaction. If monitoring is needed, renal impairment, obesity, pregnancy, kids' antifactor ZA levels are used, as LMWH has little effect on APTT.
What about the typical dosing and side effects of LMWH compared to UFH? Is the bleeding risk lower?
Bleeding is still the major complication, though meta-analyses suggest a lower risk of major bleeding with LMWH versus UFH. Protamine sulfate, the antidote, only incompletely neutralizes LMWH. It reverses anti-II activity, but only partially reverses anti-II activity because shorter chains don't bind protamine well.
So UFH might be safer if you know you need rapid, complete reversal.
Potentially, yes. For patients at very high bleeding risk, like needing cardiac surgery, continuous IV UFH might still be safer due to its more complete reversibility.
And the risk of HIT.
Thankfully, the risk of HIT is about 5-fold lower with LMWH than UFH.
Why?
Because LMWH binds less avidly to platelets and causes less PF4 release. It's less likely to induce those conformational changes in PF4 that trigger HIT antibodies. However, crucially, LMWH should not be used to treat HIT patients due to crass reactivity with most HIT antibodies.
And osteoporosis.
Also lower risk with LMWH, making it better for extended treatment.
And what about fondaparinux? It sounds quite different from the heparins in its mechanism. How does it work, and what makes it distinct?
It is indeed very different. Fondaparinux is a synthetic analog of just that antithrombin-binding pentasaccharide sequence. It's much shorter, MW1728.
So what does that mean for its action?
It's too short to bridge thrombin to antithrombin. Consequently, it binds only to antithrombin and catalyzes only factors A's inhibition. No thrombin inhibition at all. Very specific antifactors A agent.
What are its pharmacological properties and uses? Any key considerations? Maybe kidney function again?
It has complete bioavailability after SC injection. Doesn't bind nonspecifically to cells or proteins, so clearance is dose-independent. Long plasma half-life of 17 hours, allowing once daily SC administration.
But the kidneys?
Yes, a crucial point for you, the listener. Fondaparinux is cleared entirely unchanged by the kidneys. Therefore, it is absolutely contraindicated if creatinine clearance is below 30 mLm and used cautiously below 50 mLm.
Okay. Dosing and efficacy.
Predictable response with fixed doses. For VTE prevention, 2.5 milligrams once daily. For initial VTE treatment, 7.5 milligrams once daily, adjusted for weight extremes. It's as effective and safe as heparin or LMWH for DVT-PE treatment. In ACS, a lower 2.5 milligram a dose showed similar efficacy to enoxaparin, but 50% lower bleeding. For PCI, though, adjunctive heparin is needed to prevent catheter thrombosis.
And are there any specific side effects or unique considerations for managing bleeding? What happens if a patient on fondaparinux bleeds?
Major side effect is bleeding, like all anticoagulants. Crucially, fondaparinux does not cause HIT because it doesn't bind PF4. No cross-reactivity with HIT antibodies, so it's an option for HIT patients, though large trials are lacking.
But what about reversal?
This is its major limitation. There is no specific antidote. Cotamine sulfate is completely ineffective. Recombinant activated factor VII reversed its effects in volunteers, but its ability to control bleeding in actual patients is unknown. This lack of a specific reversal agent is a key factor in its clinical application.
So these parenteral direct thrombin inhibitors, or DTIs, bypass antithrombin entirely. That's quite a different approach. How do they work, and which ones are currently approved?
Exactly. They bind directly to thrombin, blocking its interaction with substrates, unlike heparins needing antithrombin. While lepridin and desiredin are gone, argatrobin and bivaludin are currently approved and used.
Let's delve into argatrobin. How does it work, and when is it typically used, especially concerning patients with kidney or liver issues?
Argatrobin is a univalent inhibitor, binding to thrombin's active site. Pharmacologically, it's metabolized primarily in the liver, so caution in hepatic insufficiency, but a significant advantage is it's not renally cleared.
So safer in kidney disease?
Safer than some others in renal impairment, yes. It's given by continuous IV infusion, half-life around 45 minutes, monitored using the APTT, aiming for 1.53 times baseline. It also prolongs the INR, complicating warfarin transition.
How do you manage that?
Either use factor X levels to monitor warfarin or stop argatrobin 2-3 hours before checking the INR. Its primary licensed indication is treating patients with HIT.
And bivalirudin, how does it differ from argatrobin, and where is it commonly used, particularly in interventional cardiology?
Bivalirudin is a synthetic analog of hirudin, originally from leeches. It's a divalent thrombin inhibitor.
Meaning it binds two spots.
Yes, its N-terminus binds the active site. C-terminus binds exosite 1, strong inhibition. It has the shortest half-life, just 25 minutes. Degraded by peptidases, partially kidney excreted. Monitored using activated clotting time, ACT, at high doses, like in the cath lab, or APTT at lower doses. It's licensed as an alternative to heparin in patients undergoing PCI, including those with HIT. It's also been used successfully in HIT patients needing cardiac bypass surgery, where that short half-life is valuable.
Okay, moving to oral options. For years, warfarin was practically the only game in town for oral anticoagulation. How does it work, and what were its key challenges that ultimately spurred the development of newer drugs?
Warfarin, a vitamin K antagonist, was indeed the primary oral anticoagulant for a very long time. Saved countless lives. It works by interfering with the synthesis of vitamin K-dependent clotting proteins, prothrombin, factors 7, IM, and X.
And the natural ones, too.
Yes. Crucially, it also reduces the synthesis of the natural anticoagulant proteins, protein C and protein S. The key challenge, as we'll discuss, is its unpredictable response and very narrow therapeutic window.
Can you explain its mechanism again? How does it interfere with making those factors?
These vitamin K-dependent factors need a modification called gamma carboxylation to become active and bind to calcium. This needs vitamin K hydroquinone. Warfarin inhibits an enzyme called vitamin K epoxide reductase, or VKOR.
Okay.
VKOR normally recycles oxidized vitamin K back to the active hydroquinone form. By blocking VKOR, warfarin prevents this recycling, leading to the synthesis of inactive or partially active clotting factors.
So because it's affecting synthesis, not factors already there, its onset isn't immediate.
That's correct, a crucial point. The antithrombotic effect is delayed until the newly made inactive factors gradually replace the active ones. Factor X half-life is 24 hours, prothrombin 72 hours.
Takes time.
Takes time. Therefore, patients with established clots or high risk need overlap with a rapid parenteral anticoagulant heparin, LMWH, fondaparinux for at least 5 days, and until the INR, our measure of warfarin's effect, has been therapeutic for at least 2 consecutive days.
And what makes warfarin so variable, needing all that monitoring?
Several things. Warfarin is a mix of R and S isomers. S is more active. It's well absorbed, long half-life, highly protein-bound. But the isomers are metabolized differently by liver CYP enzymes. The more active S isomer uses CYP2C9.
And genetics matter here.
Big time. Common genetic variants of CYP2C9 result in reduced enzyme activity. Patients with these need lower warfarin doses and are at higher risk of bleeding. Polymorphisms in VKORC1, the enzyme warfarin inhibits, also significantly influence dose, explaining maybe 30% of variability. These variants are common, especially in Asians.
Diet and drugs, too?
Absolutely. Dietary vitamin K intake, numerous drugs affecting absorption, clearance, metabolism, all add to the variability. Because of this, frequent coagulation monitoring is absolutely essential.
How exactly is warfarin monitored, and what are the target levels?
Usually monitored with the prothrombin time PT, sensitive to factors 2p7x. But PT results vary by region, so the International Normalized Ratio, INR, was developed to standardize.
How is INR calculated?
INR, patient PT mean normal PT, raised to the power of the ISI, the International Sensitivity Index of the region, aims for standardization, but issues with precision remain. Labs need to establish their own mean normal PT.
And the target range?
For most indications, target INR is 2.0, 3.0, exception. Mechanical heart valves, especially mitral or older aortic ones, need 2.5, 3.5 due to higher risk. Studies show increased stroke below INR 1.7, increased bleeding above 4.5. Very narrow therapeutic window.
What are the key side effects, and how is bleeding managed?
Bleeding is the major side effect, often when INR is too high. It can range from mild nosebleeds to severe GI or retroperitoneal bleeds or life-threatening intracranial hemorrhage. If INR is high, 3.5, 10, no bleeding, just hold warfarin. If INR 10, maybe give low-dose oral vitamin K. For serious bleeding, it's aggressive. IV vitamin K slowly, supplemented with prothrombin complex concentrate, PCC, for faster INR normalization than FFP. If bleeding occurs within the therapeutic range, look for an underlying cause, like an ulcer.
I've heard of warfarin-induced skin necrosis. That sounds quite dramatic. What is it, and why does it happen?
It's rare but serious, typically 2 to 5 days after starting warfarin. Well-demarcated red lesions, often on fatty tissues, thighs, buttocks, breasts, become necrotic. Biopsies show microvascular thrombi.
Why?
It occurs mainly in patients with congenital or acquired protein C or S deficiencies, those natural anticoagulants. When warfarin starts, it drops these faster than the procoagulant factors. This creates a temporary procoagulant state, triggering thrombosis in small vessels. Stop warfarin immediately. Give vitamin K reversal. Start an alternative anticoagulant, heparin LMWH. Protein C concentrate, or FFP, might help. Crucially, for patients with known protein CS deficiency, always overlap with parenteral anticoagulation when starting warfarin to prevent this.
And finally, warfarin in pregnancy. Concerns for the fetus.
Critical point. Warfarin crosses the placenta, can cause fetal abnormalities, embryopathy, especially first trimester, nasal hypoplasia, stippled epiphyses, and bleeding. CNS issues anytime. Fetal bleeding risk at delivery is high. So warfarin is contraindicated in pregnancy, especially first and third trimester.
It's used instead.
Heparin, LMWH, or fondaparinux. However, warfarin does not pass into breast milk and is safe for nursing mothers.
Now, these are the newer kids on the block, the direct oral anticoagulants, or DOACs, often marketed as much more convenient. What makes them so, and how have they truly revolutionized oral anticoagulation?
The DOACs have truly changed the game. This class includes dabigatran, a direct thrombin inhibitor, and rivaroxaban, apixaban, and edoxaban, direct factor ZAZI inhibitors.
What makes them convenient?
They are small molecules designed to bind reversibly and directly to the active site of their target enzyme thrombin, or factor ZA. Rapid onset and offset, half-lives allowing once or twice daily dosing. But the biggest advantage over warfarin?
No monitoring.
Exactly. They're designed for predictable anticoagulation, given in fixed doses without routine coagulation monitoring. A monumental leap.
That sounds like a game changer. Where are DOACs typically used, and are there any specific exclusions?
All 4 are licensed for stroke prevention in non-valvular atrial fibrillation. Importantly, this excludes mechanical heart valves or severe rheumatic mitral valve disease. Warfarin is still needed there.
Okay.
They're also all licensed for VTE treatment. Dabigatran, rivaroxaban, apixaban are licensed for thromboprophylaxis after hip knee replacement. Edoxaban only in Japan for this. And low-dose rivaroxaban plus aspirin is licensed for secondary prevention in CAD/PAD.
Can you give us the most critical considerations for DOAC dosing? It seems complex, but what's the rule of thumb for listeners?
You're right, specifics vary by DOAC, indication, and patient factors. The key takeaway for you, the listener, is that dose adjustments, primarily for kidney function, are essential to prevent drug accumulation and bleeding.
Okay, renal function is key.
Absolutely. For AFib stroke prevention, rivaroxaban, edoxaban are once daily, dabigatran, apixaban twice daily, with specific creatinine clearance thresholds for lower doses. Rivaroxaban uniquely needs food. For VTE treatment, dabigatran and edoxaban need a parenteral lead-in, while rivaroxaban, apixaban can start orally, often with an initial higher loading dose. These initiation differences are crucial clinically.
It's clear why routine monitoring isn't needed, but are there ever situations where you would monitor DOAC levels, and how?
While generally not routine, specific situations might call for it. Assessing adherence, detecting accumulation overdose, identifying bleeding mechanisms, or checking residual activity before urgent surgery or reversal.
How do you measure them?
Qualitatively, PT for rivaroxaban, edoxaban prolongs it more than apixaban, which needs anticoagulant assays. APTT for dabigatran, quantitatively. Chromogenic anti-factor assays for VDA inhibitors, diluted thrombin time or eccrine clot time for dabigatran. Timing of the blood draw relative to the last dose is crucial.
And what are the main side effects, especially bleeding, compared to warfarin?
Bleeding is the most common, like all anticoagulants. Big advantage. DOACs are associated with significantly less intracranial bleeding than warfarin.
That's huge.
It is. However, higher dose regimens of dabigatran, rivaroxaban, edoxaban are linked to more gastrointestinal bleeding. Beyond bleeding, dyspepsia occurs in up to 10% with dabigatran. Improves with time, less with food, rare with others.
How do you manage patients on DOACs needing surgery or experiencing significant bleeding? Are there specific reversal agents now?
Yes, this is a crucial area with major advances. Like warfarin, DOACs need stopping before moderate high-risk procedures, typically 1-2 days longer if kidney function impaired. Checking residual activity might be prudent.
And for bleeding?
Mild bleeding, just withholding 1-2 doses often works. Serious bleeding, withhold drug, resuscitate, manage source. Oral activated charcoal within 4 hours might help absorb remaining drug.
And reversal for life-threatening bleeds?
Yes, we now have specific reversal agents. Iduricizumab is licensed for dabigatran reversal. It's an antibody fragment, binds dabigatran irreversibly, rapidly reverses effects, given as a 5G IV bolus.
And for the factors A inhibitors?
Andexanet alpha is available for reversal of rivaroxaban, apixaban, and edoxaban. It's a recombinant inactive factor XA variant, acts as a decoy, sequestering the drugs. Given as 5E bolus and infusion, dose depends on DOAC and timing.
Andexanet alpha sounds great, but any caveats?
Yes, important ones. It's expensive, not universally available, often reserved for life-threatening bleeds, intracranial closed spaces. If unavailable, 4-factor PCC 2550 unit ski is effective. If bleeding continues, activated PCC or RFVIA considered.
What about reversal for urgent surgery?
Neither andexanet nor 4-FPCC have been extensively evaluated for urgent surgery reversal. Also, andexanet reverses heparin LMWH2, problematic if heparin is needed during surgery. Most surgeries might be doable without reversal, using 4-FPCC if needed. Upfront, 4-FPCC might be considered for major bleeding needing surgery, like a ruptured aneurysm.
And finally, DOACs during pregnancy and breastfeeding. Safe?
As small molecules, they cross the placenta. Strictly contraindicated in pregnancy. Appropriate contraception is essential. Should also be avoided in nursing mothers. Safety not established.
We've covered preventing clots, stopping them growing. Now the final act, actually dissolving them. This is where fibrinolytic therapy comes in, our powerful clot busters.
This is indeed the last line of defense. A powerful intervention aimed at directly degrading existing thrombi to restore critical blood flow. Fibrinolytic drugs are given either systemically, throughout the body, or via catheters directly into the clot.
Where are these powerful clot busters typically used in emergencies?
Systemic delivery is used for acute MI, acute ischemic stroke, and most cases of massive pulmonary embolism. The goal is rapid thrombus dissolution to restore blood flow.
To save tissue.
Exactly. In the heart, limit myocardial damage. In the brain, decrease neuronal death. For massive PE, rapidly restore pulmonary artery perfusion, which can be life-saving.
And the catheter-directed approach, how does that differ?
Catheter-directed therapy is more often used for peripheral arterial thrombi or extensive deep vein thrombi in the leg. Catheters with side holes deliver the drug right into the clot. Sometimes intravascular devices physically fragment and extract the thrombus. alone or with the drug, more localized.
So how do all these different fibrinolytic agents actually work at a molecular level? What's the common pathway?
All currently approved ones, streptokinase, anisotropic, urokinase, alteplase, are TPA, and its derivatives, connectoplase and retaplase, work by converting plasminogen, an inactive zamagen, into plasmin, the active enzyme.
Plasma, the clot dissolver.
Exactly. Plasmin then acts like molecular scissors, degrading the fibrin matrix of thrombi into soluble bits, effectively breaking down the clot.
Sounds powerful. How does the body naturally regulate this? And what happens when we give these drugs, potentially disrupting that balance?
The body's system is finely regulated. Plasminogen activator inhibitors, mainly PAI1, regulate activators like TPA. Once plasmin forms, it's swiftly inhibited by O2 endoplasmin. Now, here's a key concept. Plasminogen concentration is naturally twice that of O2 endoplasmin. So with pharmacologic doses of activators, the plasmin generated can easily overwhelm O2 endoplasmin,
Leading
to unregulated plasmin circulating systemically, degrading not just the clot's fibrin, but also circulating fibrinogen and other clotting factors. This is the systemic clotting state, reducing overall clotting ability and increasing bleeding risk significantly.
How does the body normally avoid that?
The natural system localizes plasmin generation to the fibrin surface. Both plasminogen and TPA bind fibrin, forming a complex that efficiently activates plasminogen only on the clot. Plasmin made there is relatively protected from O2 antiplasmin. Plus, as plasmin degrades fibrin, it exposes binding sites for more plasminogen and TPA, amplifying local lysis.
And the drugs exploit this.
To varying degrees, we categorize them as fibrin-specific, preferentially activate fibrin-bound plasminogen, minimizing systemic effects like alteplase, versus nonspecific, streptokinase, urokinase, activate everywhere, causing that systemic allolytic state.
Streptokinase is one of the older ones and sounds like it works differently, not directly an enzyme.
It does. Streptokinase isn't an enzyme itself. It forms a 1.1 complex with plasminogen, causing a shape change that exposes plasminogen's active site. This complex then converts more plasminogen plasmin.
Okay, and its properties?
It has no affinity for fibrin, activates free and bound plasminogen indiscriminately, leads to that significant systemic olytic state.
Indications and side effects.
Systemic use in acute MI reduces mortality, typically 1.5 million units IV over 30-60 minutes. Big issue. Patients can develop antibodies from prior strep infections or drug exposure, reducing effectiveness. Allergic reactions in 5%, rash, fever, chills, anaphylaxis rare. Transient hypotension is common due to bradykinin release. Anticoagulant was a modified streptokinase combined with lysplasminogen active site masked. Slowly unmasked after 5E infusion, giving a longer half-life, 1 minute, allowing single bolus administration. More convenient.
But any real advantages?
Mechanistically, few. It also doesn't distinguish fibrin-bound versus circulating plasminogen, causes systemic alarmic state. Allergic reactions, hypotension just as frequent. Trials showed alteplase gave faster reperfusion, maybe better outcomes than anisotroplase. High cost also limited its use. Urokinase is a 2-chain serine protease, directly converts plasminogen to plasmin. Unlike streptokinase, not immunogenic, so allergies rare, but it also produces a systemic landokinase, doesn't discriminate fibrin-bound versus circulating.
Indications.
Never systematically evaluated for coronary thrombolysis, often used for catheter-directed lysis in peripheral arteries or deep veins. Due to production problems, urokinase is no longer available.
Now for alteplase, recombinant TPA activase, the one often called clot-specific. How does it achieve that, aiming for less systemic bleeding?
Alteplase is recombinant single-chain TPA, has specific domains, including a finger domain mediating fibrin binding. This gives alteplase considerably higher affinity for fibrin than fibrinogen.
So it works better on the clot.
Yes, its catalytic efficiency for plasminogen activation is 2 to 3 orders of magnitude higher in the presence of fibrin. This helps localize plasmin generation to the fibrin surface.
Is the specificity absolute?
Not entirely. Soluble fibrin degradation products can also bind alteplase and plasminogen, stimulating some systemic activation and fibrinogen degradation, potentially contributing to bleeding risk despite its general specificity.
Indications and outcomes.
For acute MI or stroke, given as IV infusion over 60-90 minutes, 90 to 100 milligram total, a landmark trial versus streptokinase for MI showed significantly lower mortality with alteplase, especially in younger patients presenting early. Allergic reactions, hypotension rare, not immunogenic.
This sounds like an engineered upgrade to nectoplase.
Yeah.
What modifications were made and how do they improve fibrin specificity and outcomes?
It is a great example of engineering. Tenecteplase is a genetically engineered TPA variant designed for longer half-life and resistance to PAI-1 inactivation. New glycosylation site added to prolong half-life. Specific amino acid substitution made to achieve PAI-1 resistance. It's also more fibrin-specific than TPA. Binds fibrin similarly, but has significantly lower affinity for those soluble degradation products.
Meaning less systemic activation.
Exactly. Less stimulation of systemic plasminogen activation by those products, resulting in less fibrinogen degradation. Better safety profile. Allows convenient single IV bolus dosing for coronary thrombolysis.
Outcomes.
Large trials showed similar mortality to accelerated TPA, similar intracranial hemorrhage rates, but tenecteplase patients had fewer non-cerebral bleeds, needed fewer transfusions, likely due to that enhanced fibrin specificity. Finally, retplase, another recombinant TPA derivative, but it's truncated, shortened, lacking finger EGF, first Kringle domains. Smaller molecule.
Property.
Lacks finger domain, so binds fibrin more weakly than TPA. Produced in coli, so not glycosylated, which paradoxically gives it a longer plasma half-life than TPA.
Dosing and outcomes.
Consequently, given as 2 IV boluses, 30 mins apart, trials show it's at least as effective as streptokinase for acute MI. Similar mortality rates in comparisons.
Wow. Okay. We've really taken a deep dive into thrombosis and this incredible arsenal of antiplatelet, anticoagulant, and fibrinolytic drugs.
We certainly have.
From understanding the nuanced differences between arterial and venous clots to dissecting the precise molecular mechanisms, it's clear this field is a testament to scientific ingenuity. You, our listener, now have, hopefully, a comprehensive understanding of how our bodies respond and how we intervene, really at an elite level.
This mastery of the details does lead to an important question, though. Despite all this progress, why do thromboembolic disorders remain major causes of morbidity and mortality globally?
Right, still a huge problem.
It just underscores the inherent complexity of the body and the persistent challenges in achieving that perfect balance, preventing unwanted clots without causing excessive bleeding. The search for even better, safer targets is absolutely ongoing. It's a dynamic field.
This deep dive truly makes you appreciate the incredible, delicate balance our bodies strive for. Knowing how these drugs interact with our clotting systems, or sometimes how our own genetics affect their efficacy, that's truly powerful knowledge. Makes you a more informed patient or professional.
Think about this for the future. Given this intricate balance between clotting and bleeding, how might future drug development continue to refine precision medicine here?
Going beyond broad classes.
Exactly. Moving beyond broad drug classes to truly individualizing therapy based on a person's unique thrombotic risk, their specific genetic makeup, maybe even real-time biomarkers. The journey to truly master this space continues, and it's a vital one.
Absolutely. Well, thank you for joining us on this deep dive into antithrombotic therapies. We hope you feel far more informed and empowered by this knowledge.
Hope it was useful.
Until next time, keep that curiosity flowing.